Good afternoon, everyone. My name is Asha Usman. I work at the Mental Health Foundation Australia, and I am your host for today's webinar. We begin by acknowledging the Wurundjeri Woi-wurrung people as the traditional custodians of the land on which our office stands, and pay our respects to their elders, past and present. We extend and respect to any Aboriginal and Torres Strait Islander peoples tuning in today. On behalf of the Mental Health Foundation Australia, I would like to welcome and thank each one of you for attending today's Lunch and Learn educational webinar on new treatment in mood disorders, presented by Professor Mel Hopwood. Professor Mel Hopwood is currently the Ramsay Health Care Professor of Psychiatry, University of Melbourne, based at Ramsay Clinic, Albert Road. The Ramsay Clinic, Albert Road, provides inpatient care within the professional psychiatry unit as well as outpatient consultation focused on secondary psychiatric opinions. In addition to Professor Mel Hopwood's clinical role, Malcolm has a long track record of involvement in psychiatric research focused on mood and anxiety disorders, psychopharmacology, and psychiatric aspects of acquired brain injury. I would like to welcome Professor Mel Hopwood for his presentation.
Thank you, Aisha, and it's a pleasure to join you and everyone else. Let me just quickly share my screen and we can make a start. There we go. So, welcome everybody. It's a pleasure to join you again. And today I want to talk about some of the things that are new in mood disorders. Now, this is always a little bit of a selection of things because there's so many new things happening. And I'm going to focus predominantly on what's new in major depression. Of course, some of those things may be relevant in other types of problems as well. So, let me do that. It's always good to go back to basics a little bit and say, well, what's new in terms of the way we diagnose mood disorders? And some of you will recognise this diagram from DSM-5. This was from the original version published in 2013, and it was updated with a revised version just a couple of years ago now. And look, the quick statement is nothing much has changed in the way we diagnose depression. And that's important. Similarly, nothing much is diagnosed in the technical way we diagnose bipolar disorder. Some of you will be aware of the trend that bipolar disorder is probably diagnosed a little more broadly than it was, say, a couple of decades ago, particularly with people with what we call bipolar 2 disorder, where the highs are a small part of their illness and it's predominantly depression. There's a bit of overlap there with other problems that might cause mood instability. We can see that, for example, with some types of anxiety disorder or in some types of personality disorder. But bipolar 2, we're generally looking for people who've got more sustained mood disturbance. But fundamentally, the criteria for how we diagnose depression hasn't changed over the last few years. I'm going to have to advance them each time like that. One thing that I think's changed is a growing recognition of just how big a public health problem we're talking about. Now, I suspect to people dialing in today, this is not new news, but actually I think we all have a role in advocating around the need for treatment, recognition, treatment, and better treatments for mood disorders like major depression. Because whilst I think Beyond Blue and other organisations have done a wonderful job in destigmatising the diagnosis, I think in some ways the treatments of depression are still quite stigmatised, and people often discuss them in a way that suggests they're nervous about them. And really we need to accept we want to get on top of this problem with effective treatment. Because right now in Australia, we've got almost 1.5 million people living with depression, about 6% of the population. That's not acceptable. Not acceptable. We should be aiming to do better. A big part of the reason for that level of disability is the high rate of recurrence. And sadly, that's probably something some of you online know. The best data is now quite old from a North American group that says if you have major depression, your chance of recurrence in the next 5 years goes from the population rate of 20% lifetime to 50% in the next 5 years. Further, major depression is still a difficult disorder to treat. So we know the first treatment you have, be it an antidepressant or good CBT, about a 40% remission rate will be achieved, but only 40%. And with each subsequent treatment, that rate goes down, 30% with the second, and then down to mid-teens with the third or fourth. The study didn't look at the fifth, sixth, seventh. So we've got a highly recurrent condition that our current treatments help and often can work very well, but are not perfect. Together, that adds to the disability that we see in our community, and we clearly need to improve this situation. Particularly once you've failed a couple of antidepressants and you get into what we call the treatment-resistant depression group. This is where we really like to improve things, because we know that once you've had treatment-resistant depression, things tend to go worse, which is sort of not surprising, is it? Where people with treatment-resistant depression stay ill for longer, they tend to be more likely to have other comorbid problems that go with their depression, and they have an almost 7-fold increase in suicide attempts or self-inflicted injury, the very serious end of the problem. So we don't want you to get into that recurrent and treatment-resistant depressive group. How do we stop you getting there? Because once you get there, we recently completed a study in our clinic that backs up not only are you very likely to be comorbid with problems like anxiety, substance abuse, PTSD, or an abnormal personality, but you're very likely to need repeated admissions to hospital, and your quality of life is markedly impaired. Now, you could say, well, the study's done in hospital, so people are particularly likely to be impaired, and that's true up to a point. But if we look at their measures on the AQOL, an Australian-designed instrument measuring quality of life, where lower scores, it's important to say, mean better quality of life. The people with major depression were worse in all areas of functioning. Interestingly, not just the psychosocial domain, but also the physical health domain. Again, in looking at new treatments to improve this situation, so we've got good reason we want to improve it. In looking at new treatments, we really need to have a good sense of, well, where do they fit into what's current good treatment? Because we can get very excited about the headline, can't we? You know, new treatment will cure everyone. We need to go back and say, hang on, what's proper current good treatment look like? And this is the most recent guidelines from our Australian and New Zealand College of Psychiatrists that I had the good fortune to be one of the authors of, a group led by Jim Marley from Sydney. And it aimed to define what current good treatment looks like. And it set out the steps in the treatment of major depression, and actually the same is true for bipolar disorder. It said for major depression in particular, there are a set of basic actions that everyone must have. That's attention to lifestyle changes and issues in their life that might be impacting on depression, as well as psychological interventions for everyone. And now that is a change. previous guidelines tended to say mild to moderate depression, we would treat more with psychotherapy, whereas moderate to severe, we'd go straight to biological treatments like medication. That was based on the idea that severe depression, your capacity to engage in therapy might be affected. And sure, that's sometimes going to be true. But actually, it's probably only true in the tip of the iceberg people with the most severe major depression, the people like me see. For most people in the community, even with severe depression, psychotherapy can still be helpful. So it should be given or at least offered, because it won't be everyone's choice or suit everyone. Then choices are things that you can add with pharmacotherapy, traditional antidepressant medication being the obvious next step, and only then moving to alternatives, things like ECT and more complex strategies. I want to say that most of the new biological treatments we're going to talk about today fit into that alternatives group. That is, do the basic things that we know very well have a good chance of working first. Don't race straight to the new just because it's kind of shiny and exciting and attracting a bit of media attention. You might be interested in what lifestyle interventions we thought had the highest level of evidence, because we hear a lot about different lifestyle things that can help depression, and at times they're promoted as being the answer to everything. We felt there's good evidence to support the role of regular exercise, noting that the best evidence is actually for quite vigorous exercise of at least 30 minutes every day. A walk is a good thing, but probably the better evidence lies with more vigorous exercise. Attention to sleep hygiene, attention to diet. And we're really seeing some interesting studies emerging now that are starting to say good diet, most evidence with a Mediterranean style diet, may well actually help treat depression using collaboration with other treatments. There may not be something specific about the Mediterranean diet as opposed to just a good diet generally and the avoidance of the bad things that we can all get sucked into. Just as important in this sort of lifestyle area, addressing issues like alcohol and substance misuse, and for many people, that actually may be the main focus of treatment. Looking after physical health generally, and don't forget the obvious things like if you don't have stable housing or you're currently exposed to domestic violence, they may well make your depression much harder to treat. That's not new news, is it? But it's interesting how they can get forgotten at times or underestimated. I just want to comment for a minute about the systems we operate in to provide these treatments for major depression. And in Victoria, in particular, for those of you who are in Victoria, we've recently had a major Royal Commission into mental health that tabled its report probably about 18 months ago now, or slightly longer. And it started with a very dramatic announcement by the Premier, didn't it? The system is broken, which is a dramatic kind of statement. Now, clearly, there are a lot of aspects that the Royal Commission looked into, many of which were around issues of, for example, involuntary mental health care in public mental health services, which aren't relevant to the vast majority of people with major depression. Together with other people, I gave evidence to the Royal Commission, and I joke, this is the slide that shows me being dragged away after my evidence. That's not strictly true. Many of you, of course, will recognise this was a very bizarre photo. When Julian Assange was taken out of the Ecuadorian Royal Commission, it was a very strange image, wasn't it? But in my evidence, I was specifically asked to talk to mood disorders, and in particular, the difficulties of access that many people with disorders like major depression have in accessing our public mental health services. And I don't think that's a contested fact. That's a lot about resourcing. It's possibly also about, because the activity of our public mental health services has to focus on disorders like psychosis that necessitate involuntary care, there's not a big window for the treatment of mood disorders. The Royal Commission have made some recommendations about expansion of services within Victorian public mental health. And some will be aware of the movement to the development of new local services. A shorthand way of describing them might be like headspace for adults. And hopefully, like for young people, they're going to improve access to evidence-based treatment for major depression for all Victorians. The private system, of course, is there, particularly inpatient care for those with private insurance, but we want to make sure there's equity of access for everyone. So I think that's a really important step that will get rolled out gradually over the next few years. Service systems matter, don't they? Because we can talk about treatment till the cows come home, but if you can't get into it, it doesn't mean too much. What about what's new in psychotherapy treatments? Well, the guidelines said we recommend them for everyone with major depression, except perhaps those right at the very edge of severity, the most severe, or those who don't want it. But what psychotherapy? And is there anything new? We'll come in a minute to the whole psychedelic-assisted psychotherapy, which arguably is the newest kid on the block. But amongst traditional therapies, most of the main players have been with us for a while now. CBT, IPT, interpersonal therapy, which is not as widely available in terms of training in Australia. And then the kind of new third wave of structured psychotherapies. And also, of course, the dynamically oriented therapies that have been around for a long time. Perhaps the most recent evolution has been digital delivery of psychotherapy. And this kind of has had a big kickoff during COVID with the kind of difficulty accessing face-to-face therapy, but has been around before that. And there's a lot of debate about, is it the same as face-to-face therapy? And clearly there will be individual differences in how people feel about that. The evidence suggests they're equally efficacious, but there are challenges in that evidence, aren't there? You can't be blinded as to whether you're receiving internet-based or face-to-face therapy. There's also questions of who the sample were and how they were selected. The evidence does support internet-based therapy can be very effective. It certainly suggests that we're talking here about internet-based therapy with a therapist as opposed to structured activity online. With that sort of structured activity online without a regular therapist, the evidence says it does work best if there is access to a clinician as part of the program if you need it. The clinical consensus amongst the guidelines group is still that face-to-face therapy has its advantages in many situations, but we will see, I have no doubt, the continued spread of internet-based therapy. What therapy? The guidelines said the biggest body of evidence is with CBT and IPT. Interestingly, they're often put forward as you do therapy or you do medication, and the evidence historically was that adding them together, which might seem kind of logical at all levels, didn't necessarily make a difference. But the latest meta-analysis by Pim Kuipers and group from Europe says actually there is an additional benefit by putting the two together, which intuitively makes sense. Interestingly, in the guidelines, there was a discussion about the role of psychodynamic psychotherapy, particularly short-term dynamically focused therapy, which does have evidence supporting it in the treatment of major depression. Not as big a body of evidence as CBT, and there probably aren't as many trained therapists now available as there are in CBT. So it's also a little bit about availability again too. Right, let's move on to the newer biological treatments, because I want to make sure we leave lots of time at the end for questions. I guess the treatment amongst the new biological treatments that's got the most established evidence is ketamine and its equivalent racemic isomer, esketamine. So ketamine, as many of you know, is an anesthetic agent used in humans, often discussed in the media as a horse tranquilizer, which I don't think is meant as a compliment when people say it. It is a human anesthetic. The doses we're talking about in the treatment of major depression are way below those used as an anesthetic. It works on a transmitter system in the brain called glutamate, which is different from the way all of our conventional antidepressants work. Ketamine is delivered by an injection, either intravenously or increasingly people are looking at subcutaneous injections, like people used to traditionally do with insulin. And the evidence is it can produce a rapid improvement in depressive symptoms in people with treatment-resistant depression. After a single dose, that tends to reverse unless you keep dosing. Esketamine is an isomer. So all molecules like ketamine, if you like, come in a left-hand chemical version and a right-hand. And esketamine is purely the left-hand version. And the argument goes it may have stronger affinity for the relevant receptor in the brain. There's debate about that. Esketamine is available in an intranasal version. It's still got to be delivered on site at a clinic or a hospital, so that's a limit. But in some ways it's easier with an intranasal spray. This is one of the positive studies. There are negative studies with esketamine saying over time, added to a new antidepressant, it was superior to just starting on an antidepressant alone in people with treatment-resistant depression. Importantly, this study said that if you continued on esketamine, if you were a responder, it kept you better. Not everyone, but certainly much better than stopping it after an acute course of treatment, which is judged to be about 4 weeks. That's because it has a quicker time frame of response than generally with traditional oral antidepressants, the SSRIs and SNRIs and so on. So there's a body of evidence to support esketamine. Because it's sponsored by a large pharmaceutical drug company, it probably has more big studies than ketamine, but it doesn't necessarily mean ketamine is worse or better. We're kind of developing evidence about that. It just means ketamine, because it's a very old drug, there hasn't been as much money to sponsor research, which is a problem. What are the side effects with ketamine? Some of you will be very aware of the fact that ketamine, of course, has been known as a drug of abuse in some people. So obviously we're very interested in that. It's worth noting that ketamine abuse involves doses at least tenfold the kind of dose we're using here, where you can only use it at a treatment site. So there's little risk of you being able to take it away. What are the commonest side effects we see? You can get a transient increase in blood pressure, We've treated about 60 people with esketamine at Albert Road, and whilst we've seen a few people with a brief increase in blood pressure, it's not needed intervention. So it's not serious, but we need to observe it over 90 to 120 minutes post-dose. Dissociation is a sense that you have an altered sense of consciousness. Here in this, it was leading to stopping it. So when it was serious, so like when the blood pressure increase was serious, and you can see the numbers are very low. Mild dissociation is actually very common when people have ketamine, kind of like the dissociation you have when you've had a glass of wine, not 6, just 1, where you feel just mildly numb. And that's very variable from person to person, I know. But you can see overall, the rates of having to stop esketamine in this study were quite low. And the best data we've got with ketamine itself, it's probably pretty similar. So they actually are quite well-tolerated drugs and seem to be useful. This was earlier data. We've now treated about 60 from Albert Road. These were people who got into it in an early access program. And that's relevant because unfortunately, esketamine is still not on the pharmaceutical benefit scheme, and it is very expensive. We treated people who actually hadn't failed 2 treatments. Most of them had failed at least 7 or 8. So the naturalistic response rate, we suspect, is going to be quite low with any treatment at this stage. We saw a significant drop in their Hamilton score. That's a rating scale of depression, and an average drop of 7 points. Everyone would say that's a pretty clinically meaningful drop. And about 20% of people got into remission. Now, that might not sound that high, but if it's treatment number 8 or 9, I think that's probably a lot better than with other things. So we think this is a useful treatment and adds to what we've got to offer when the first few things are not working. One of the questions I most often get asked when talking about new treatments is, where does medicinal cannabis fit in? So as many of you will be aware, we've had a change in the regulation of cannabis with the introduction of medicinal cannabis in Victoria and in most states of Australia now, and certainly in a number of other countries, particularly the US. Let's put aside for the minute all the political issues about that and the debate about whether it's really part of a push to legalise cannabis. That's not for me to kind of comment on. What we've seen is the growth of access to medicinal cannabis. I would comment it's interesting that for many people, that's occurring through a specific cannabis prescription service. And I am a little bit worried that for some of those, the level of assessment of their mental health may not be as high as I'd like. Because many of you would be aware there are specific situations where we would strongly recommend against the use of cannabis. And that might be, for example, in someone who's got a history of psychosis, either schizophrenia or with bipolar disorder, or a strong family history of psychosis to suggest they're at risk, because we know cannabis can increase the risk of psychosis. It's probably THC, one of the components of cannabis, that causes that risk. The other main component, and there are actually many in medicinal cannabis, one of the other major components is cannabidiol, or CBD, which does not appear to carry that risk of psychosis. Cannabidiol is available now through some manufacturers in a relatively purified form. The original push for medicinal cannabis was particularly around the treatment of pain and some rare forms of severe early life epilepsy. Excuse me. And in those two indications, there is evidence. So I'm not criticising that at all. And we do acknowledge that pain and depression have significant overlap. What's the evidence for medicinal cannabis in major depression? Because it kind of gets added in a lot to the claims of benefit from cannabis. Well, there is a little bit of evidence suggesting short-term, i.e. a day, benefit of cannabis for major depressive symptoms. And many people report who've been depressed, I used cannabis and it chilled me out, or I slept. And for many people who've been extremely distressed, that can feel very beneficial. But what we then have is considerable evidence that over time cannabis can, and I emphasise can, worsen aspects of major depression, including cognitive function and potentially depressive symptoms themselves. That may be directly, in the case of motivation, or indirectly by impairing their ability to engage in helpful social contact, for example. Now, clearly there's a dose effect here. Not everyone who uses medicinal cannabis uses doses that affect cognition. And there's clearly a debate going on about the issue of driving that some of you may have heard about on the radio this morning. So there's a lot within this, and I don't wish to say individual experience is always the same. That's not true. More importantly, are there good, well-controlled studies that say, used, if you like, as an antidepressant, cannabis long-term benefits major depression? And the answer is no, there is not. So at this point, I don't believe it should be recommended as a treatment for depression. Many people with major depression use cannabis. I don't want to sound naive about that. And many will tell me, I feel it's helped me. Particularly for some symptoms, sleep being the classic example. But are there good controlled studies that support that? No. And are some of those people possibly overinterpreting an initial short-term benefit to believe it's still benefiting them? Maybe. Do we need more evidence? Absolutely. And is it possible that the effects will be variable? So some people may benefit and others don't, or it doesn't do much either way. Yeah, I'm sure that's true. How do we identify those that it might help? I mentioned cannabidiol before, the other main element in cannabis, not THC, that cannabidiol is the non-psychosis promoting bit, as a very broad statement. And actually there is now building a body of evidence that says it may be useful in the treatment of anxiety disorders, like generalized anxiety. We know about 80% of people with major depression, and probably not a lot less people with bipolar disorder have significant problems with anxiety, even when they're not depressed. So there's a big overlap with anxiety. Is it possible that in the future we'll be saying cannabidiol might be useful? Yes. So if I get someone who comes to see me and says, I really want to try this, do you have any advice? Mine would be, I think you should think about those products that are available that are cannabidiol exclusive or usually cannabidiol predominant. That's not medicinal cannabis, which is more a spread between THC and cannabidiol. In fact, the truth is it's a bit unpredictable at times what's in it. So we need a bit more information at this stage about both medicinal cannabis and cannabidiol, and I don't feel they've reached the level where I'd recommend them as an option regularly, unlike ketamine, which I think is now approaching that level. Of course, the other big news is the emergence of psilocybin. And of course, in PTSD, the emergence of MDMA. And I apologise, this is copied from the TGA website, because I really think it's important to say, what is it that the TGA have approved in this area? So many of you will be aware that earlier this year, Therapeutic Goods Administration changed the scheduling of psilocybin, the active ingredient in magic mushrooms, and MDMA, otherwise known as ecstasy, for their use in major depression and PTSD, respectively, in facilitated psychotherapy specifically, not just as a treatment standalone. Many of us were a bit surprised, not to say that there's no evidence supporting this practice, but that the level of evidence hadn't got to the level usually a new antidepressant would be required to breach this threshold. Now, part of the challenge is these aren't necessarily sponsored by a large multinational pharmaceutical company, so that limits the money available to sponsor very large trials. And they'd be expensive because you're paying for both the drug and the therapist. So, it starts to become quite expensive. So that's a limit on the trials we can do. The College of Psychiatrists has issued a statement expressing some caution. But let's look at what the TGA said. It said they can be prescribed specifically by authorised psychiatrists, and we'll come to what that means, for the treatment of specifically major depression and PTSD respectively. You cannot use them for anything else. Only psychiatrists can prescribe, and those psychiatrists need to be authorised by the TGA and approved by a Human Research Ethics Committee, an ethics committee. Both those steps are necessary. That doesn't mean that they're conducting research, which is what we usually think of as an ethics committee, more that they're presenting to an ethics committee, this is how I'm going to use it, and it would be generally expected to be in accordance with the kind of protocols that have been developed in the existing research, and it's clear and transparent how the therapy will be delivered. So there's quite tight restrictions. Are there people out there currently seeking these treatments with or without this regulation? And I'm not authorising or saying I approve of anything, just acknowledging a reality. There are. And I think that's a concern. The evidence we've got suggests there may well be something useful here. What it is that's most useful is still up to some degree for debate. Psilocybin acts strongly at the serotonin 2A receptor in the brain. Some of our antidepressants already target that actually, although usually not in isolation, the way that psilocybin does, or relative isolation. Is it psilocybin that's making a difference? Is it the action of psilocybin and the descriptions that many people give of the experience of taking it is that I feel like my brain has become open and I connect things in a way that I previously had not, and or feel able to discuss things that I previously had not. So much of the work around PTSD has been around the discussion of things that were previously difficult for an individual to talk about. And intuitively, if that were all true, that could well be a very useful thing. There are different methodologies and manuals about the type of psychotherapy to be utilised under the influence of psilocybin. So we're still settling on that a little bit. And clearly, a person is in a vulnerable condition when they've taken one of these agents. So it needs to be done in a very safe and well-managed way. So there's a bit to think about. The major bits of evidence supporting this. This is an open label trial from a group at Oxford, led by Guy Goodwin, that looked at the effect of different doses of a single dose of psilocybin in people with major depression. And you can see many of them reported a dramatic improvement independent of the dose fairly quickly. There was a reduction in that level of improvement over time, but they still remain significantly improved, particularly those who took the largest dose. So this was partly a dose-finding study. What dose of psilocybin, appropriately produced, not picked in the wild, for all the reasons we recently know, might be most effective. There is one major trial compared to a currently available antidepressant, Citalopram or Lexapro. This was a study published, both of them were in the prestigious New England Journal of Medicine. And this study compared psilocybin, limited number of dosing, versus escitalopram, given as per usual dosing. And you can see that there was an initial more rapid improvement with the psilocybin, and there was numerically in the main depression rating scale a retained improvement for psilocybin compared to the escitalopram, although statistically they weren't different at 7 weeks. It may be that that's about the sample size, and a larger study would find a difference. The other scale they used, the Warwick-Edinburgh scale, is a scale used in people with depression to measure, if you like, more the aspects of positive mental health, positive affect, return of pleasure and enjoyment, an ability to engage in treatments, and to engage in life, I beg your pardon, rather than treatment. And there's some evidence that says actually in people with depression, standard antidepressants sometimes help the negative emotions, low mood, sadness, and so on, that aren't as good at restoring positive mental health. On that scale, psilocybin significantly did better than escitalopram. So interesting evidence that clearly says psilocybin-assisted therapy is worthy of further investigation and may well ultimately become a mainstream option, particularly in depression that's not got better with the first few standard treatments. I think that will be its place. I don't think personally this is the first thing that we'll be doing, but time will tell. It's important to understand where the level of evidence is with this, because right now it's getting an incredible amount of publicity.
Thank you, Professor Hopwood, for your insight. Unfortunately, that's the time that we have for today. I would like to take a moment to thank each one of you for joining us for today's highly informative webinar on new treatments in mood disorders, presented by Professor Malcolm Hopwood. If you would like to rewatch this webinar, it will be available on our YouTube channel. Lastly, I would like to mention that in addition to our educational webinars, the Mental Health Foundation Australia offers other mental health support services, including affordable $20 counseling sessions through the Wellness Hub Psychology Clinic, available in person or online via telehealth, as well as our monthly support group programs for a range of mental health conditions. For more information about our services, please visit our website at www.mhfa.org.au. That concludes today's webinar. Once again, thank you all for attending. Bye for now.